It's now my pleasure to welcome Marina Kastelan to the stage. Marina is a neuro-oncology nurse practitioner, and a damn good one, I'd have to say. So thank you for your time today, Marina, and she's going to talk to us about living with a diagnosis of a brain tumour. Thanks, Marina.
So I kind of feel like I'm preaching to the converted, because a lot of the people here know the symptoms and challenges they go through. I suppose it's just acknowledging that they exist and, you know, the effects of them more than anything. So I've sort of put the presentation into what initially happens and what brings people into hospital. So the effects or symptoms of a brain tumour, the side effects of the treatment that we cause in regard to medications, radiation, chemo, but also acknowledging the cognitive changes that occur, which can be different for different people. Okay, so this is just the initial presentation for people. It's generally a quick admission, or not a quick admission, a quick presentation where people present with headaches, an onset of a headache or a persisting headache that they're going back to the GP for, increasing drowsiness, nausea, vomiting, a sudden seizure out of the blue, changes in mobility where a leg or an arm doesn't work as well, or some limb weakness, speech changes where the patient is presenting confused, they're using the wrong words, that expressive dysphagia, or personality memory changes or confusion where maybe a partner's sending you up to the GP to get reviewed because they're noticing some changes and can't quite work out what's going on, or a sudden change in vision. And for some reason we seem to see where we get a few people that'll present with an occipital lobe tumour and all of a sudden they've had complete loss of vision down one side, smash a car, present to emergency and next minute find out they've got a brain tumour, or where they're presenting with double vision and urinary incontinence. So just a brief look at different parts of the lobes of the brain and why these things occur. And obviously your symptoms will be different according to where your lesion is. So around that temporal lobe is around speech, behaviour, memory, your emotions, that sort of thing. The frontal lobe is usually around mobility or movement, your personality, intelligence, behaviour, how you make decisions, that sort of thing. Occipital lobe is more towards your vision, and the parietal lobe is that reasoning, reading, comprehending, telling left from right. So those sorts of things will occur depending on where your actual lesion is, and that's how people present in different ways. Just a quick slide. So if you see here, I've just talked about primarily high-grade tumours here. So if you look at the percentages here, pretty much majority of the tumours are in that temporal, parietal or frontal lobes of the brain. So when you look back on this slide and you have a look at frontal, temporal and parietal lobe, they're the sort of symptoms that people will present with or have ongoing issues in. So just to talk about the cognitive effects of having a lesion in these parts of the brain as well, because that is a lot of the ongoing issues that we have beyond the initial presentation, and that'll be around the attention, concentration, processing speed, executive functioning, making decisions, those sorts of things, depending on where the lesion is. And some of the things that Dr. Cole spoke about, so that's spatial awareness, recognising, you know, that your arm and leg on one side's actually there, and those sorts of things. So when we talk about cognitive function, there can be challenges with memory where you end up with poor short-term memory. I usually find that long-term memory is usually very good, but the short-term memory for what's happening here and now, remembering appointments, medications, those sorts of things can be difficult. Or difficulty with comprehension and attention, which plays a part when you're actually still trying to work, so maintaining the attention with the job that you're doing. Behaviour can sometimes be irrational, where there's lack of insight to the loss. So people, and that sort of sometimes comes into return to driving, where there's a deficit and the person has got lack of insight and constantly wants to return to driving where the ability's no longer there. Poor ability to plan, make decisions, realise importance of certain tasks, or loss of word finding or speech, those sorts of things. Also the altered visuospatial and construction skills, the sensory and perceptive stuff. So even with speech, where you've got receptive dysphagia, so you're having trouble understanding what other people are telling you. Issues around language, memory, mood, thought, content, all those sorts of things. And then that higher executive functioning and intellectual function. All these things make it quite difficult to return back to a job that you were previously doing. I just wanted to bring this up again because we sometimes forget about these, but these fantastic fact sheets were put out years ago now, weren't they, Liz? But they're still really relevant, and I think they really help around the cognitive changes, just so that potentially the patient and the people around them can understand why the cognitive changes have occurred and what we can potentially do about it. So maybe setting up a task, getting calendars, getting pop-ups in your calendar or phone, writing things down, so making tools around how to improve the deficits that you've potentially got. And there's lots of these fact sheets available. This one's just on memory. There was about 10 of them that were produced at the time, which I find are a really good resource for this patient group. And then I think another part of the challenges that patients and carers face is just the difficulties facing the diagnosis of a brain tumour. It's usually a sudden event and it's life-changing. And these practical things, just as the Cancer Council rep spoke about, is the increased cost of the treatment that you're having when you're facing an area where you're not actually getting income in, or you're getting less income in. So it makes quite stressful from a family perspective, that inability to drive. So I find with a lot of other cancers, lung cancer, breast cancer, the patient's still able to drive themselves in, whereas the patients I see, they can't drive, and so you're relying on friends, family, somebody to actually take time off and actually drive you in. And there's that whole sense of loss of dependence as well. Difficulty understanding the terminology, and the booklet that came out today that was launched here, I think, is a really good resource around that terminology and actually asking questions, and also having the ability to say, actually, I don't want to know. You know, I think that's really an important thing for us as healthcare workers, because I think we're all about educating people. I'm really big on educating. I think if people are empowered with education, they're going to deal better with, what they face. And then the challenges around returning to work and potentially not being able to do what you previously did, and then the mood changes that will occur with that, and then changes within the relationships, so partners, children, that sort of thing. And I think these sometimes are the harder things to deal with than the physical problems that you undergo. I'm going to jump on now to the symptoms or challenges that we create when we give you treatment. And this sometimes will be a short-term thing or a long-term thing around the treatment pathway. So those initial side effects where you lose your hair in the patch of radiation, the increased fatigue, and the increased fatigue makes your concentration, attention, those things harder to deal with. The lowering of your blood count if you've had chemotherapy, any nausea or vomiting, that sort of thing with the chemotherapy. We don't often see it with the drugs we use, but patients can still feel off their food and not feel as good as they previously did. And of course that thing that we're constantly trying to challenge is the increased brain swelling around the radiation period, or obviously when you get diagnosed with the tumour, around the radiation, after the radiation, and can come back sort of months after or when the tumour potentially returns, if that's what happens. And then the long-term effects, I think the fatigue is an ongoing and true thing, and that will really impact people's return to work. The risk of stroke, it's very small. I think in the years that I've been doing my job, I think I've only seen 1 or 2 people ever have a stroke. It's not common. But the other big impact is the neurocognitive changes that occur, whether it's from the tumour itself or the treatment that you've had to undergo. And that leads me on to the medication management and the side effects of those. And these drugs, you know, the potential for brain swelling, seizures, we then have to try and control those things. So you end up using drugs that cause big ongoing symptom problems for patients. So dexamethasone is a very common drug. It's a steroid. It's the only drug that we've really got to control that brain swelling. We're constantly trying to get rid of it because of the negative effects of the drug. The main thing is around that muscle wasting or weakening, where you just lose, you know, the big muscles in your legs and bottom, and you can't sort of get around. The ferocious appetite that people get on it, they put on weight. It's usually fat as opposed to muscle, and they tend to lose muscle. The skin fragility, you know, you bang yourself and all of a sudden you're covered in bruises. The potential increased anxiety or dexamethasone psychosis and poor sleep associated with that. And, you know, I say to people, if you stay awake long enough, even if you went from Sydney to Heathrow, you had poor sleep on the flight over, you turned around, came back, poor sleep and tried to go to work, you're nearly going mad and can't function yourself anyway. And I think for some patients with the steroids and the lack of sleep that they're getting, that they're in that constant sort of battle all the time, and then still trying to return to work, undergo treatment, have relationships, those sorts of things. Dexamethasone plays an absolute havoc if you are a diabetic, and things like candida or thrush, pneumocystis, herpes will become more predominant in the use of dexamethasone as well. And then we've got the issue with the anti-seizure medications that we use, so the anticonvulsants, where, you know, you're needing to put people on anti-seizure medication to control the symptoms of seizures or prevent seizures, but these in themselves have issues. Some patients can be allergic to medications. Sometimes we need to titrate the levels or the blood levels of the medication that we offer. This is changing a little bit now because the medications have gotten a lot better over the years. Keppra is a bit of a doozy for really causing terrible depression. So it's managing people's mood in the face of needing to keep them on an anticonvulsant. I've found with young men, they can become very angry and aggressive with Keppra use, you know, so you've got young children sometimes in a new marriage, and then you're adding in anticonvulsants, which potentially can cause mood changes, anger, you know, within a family unit. It's hard to manage that sort of thing. And then obviously with seizure management, some patients can be, you know, on 2 to 4 anticonvulsants trying to control their seizures. So, you know, hugely impact patients from that perspective as well. So after all of that negative talk about the symptoms that we can create or that are being done, I thought I'd put up a slide of what actually can be done. And a lot of it is around trying to support the emotional well-being of patients and their carers, making sure that they've got access to the medical staff pretty quickly if things are changing, and there is something that is fixable. I'm a big believer, as I said, in education and information. If people understand the changes and why they're happening, they're much more open to discuss them and try and get help about it. Of course, link into clinical psych or psychosocial assessment and the provision of required care that's needed, and that's for the patient and the family and kids, especially if you've got teenagers or younger kids that aren't quite understanding why the changes are occurring. And a huge one there, I didn't actually add it on, but obviously the allied health, so physio, OT, social workers, and the assistance through the ACAT assessments and NDIS. So the ACAT's the Aged Care Assessment Team for those over 65, NDIS under 65. And then obviously the practical and financial support through the Cancer Council. These supports, as we spoke about, and that got launched here today, which is a great resource. And you see I took a snapshot of your new front page, yes. With these resources, like It's Okay to Ask, and even though the information can sometimes be overwhelming, I think information like this allows you to take it home and read it another time, or pull it out and read it, when things change, because that's the thing with brain tumour treatment. I think things can go up and down, and you'll have good periods and bad periods. So it's, it's in ebbs and flows. So that's all I had to say.